So I'm going to focus on some of the treatment aspects, and hopefully you'll use your question cards to highlight some of the issues that surround this. So we hope this will be as much of a dialogue as possible. This is a very complicated slide, but when you ask, when people are studying a disease at a very high level, cancer, cardiovascular disease, arthritis, they tend to recognize the fact that it's not one single domain, because the radiologist might think of ankylosing spondylitis as an X-ray abnormality. The immunologist might think of it as too much IL-17. The clinicians might try to figure out how to improve the function or control pain better. But the patients themselves have a whole different take and different set of goals sometimes, and how we actually harmonize all these different aspects of disease management with the patient at the center is really what this is all about. So there's actually a large body of research that looks at this from a systems point of view, and it really transcends ankylosing spondylitis. It's how we actually think about health and disease collectively, where we bring all the expertise all the way from psychologists to social workers to nutritionists to physiotherapists, to bring that whole team together with the patient at the center. But just to highlight a couple of the issues on treatment now, Chris Hawk is about to introduce some important concepts on physiotherapy, so that's great. And just to reiterate what Michael said, from the point of view of the management of ankylosing spondylitis, for the physician, the rheumatologist, this is really an important concept. And we always are, when we talk to our trainees, our medical students, or our community physicians, we keep emphasizing that this is really the cornerstone of where it all begins, because we can do pretty well sometimes on the right drug and the right patient at the right time, but without this comprehensive understanding and without integrating in an important program of exercise and physiotherapy, we're not going to see the results we need. And as you know, if you've been through our clinic, you know we're really big on talking, and we learn a lot from our patients, and we try to provide as much information as possible. We're currently developing a template for research. This is actually from one of our patients in the Toronto Western Clinic. She's a poet, as you can see. She has ankylosing spondylitis. And she points out that Procrustes, who is a mythological figure who got stretched and contracted, if you remember your Greek mythology. And she points out here that ankylosing spondylitis has a lot of parallels with some of these Greek mythologies that kind of force you into a tension with the environment that you're living with. So I think if there are any poets here, submit your poems at the end of the close-up, so we'd really appreciate that. So after an informed session and advice from the physiotherapist, you're back to what we call the pharmacological treatment and the so-called anti-inflammatory agents, or otherwise known as non-steroidal anti-inflammatory agents, or abbreviated as NSAIDs. So this really has been the cornerstone of the management of this disease. Certainly even up until 1975, we only really had aspirin. And then with the advent of ibuprofen, and then diclofenac and indomethacin, meloxicam, over the next 20 to 30 years, we had a broader array of non-steroidals, and they clearly make a difference. And that's really the beginning point. We have a number of patients in our clinic who are doing very well with this combination of the exercise, physiotherapy, and non-steroidals. And their disease management for symptoms and function is very satisfactory, and that's important. Are the NSAIDs, are they just for control of symptoms? It's an ongoing discussion about whether drugs like naproxen and Motrin and diclofenac are just symptomatic control, or are they actually making a difference in the disease? So this is a study from our colleagues in Germany, and that looked at the vertical axis here as progression of X-ray changes in the spine, basically looking at the formation of new bone spurs in the spine. So the higher the vertical axis, the more change in the spine. And you can see here that patients that have an elevated C-reactive protein, so again, if you've had blood work done in our clinic, we follow particularly the sedimentation rate and the C-reactive protein as markers of inflammation. In patients that have these elevated markers in their serum, it really makes a difference if you're taking high dose or full dose anti-inflammatory drugs. It actually seems to delay the progression of the disease versus patients that don't. It's an important question that may come from the question. It's a common question we deal with in the clinic, because if this is actually true, then it's not just symptomatic control. Maybe we really should be targeting a regular tolerable dose of NSAIDs. Notice, however, if the sedimentation rate of CRP is normal, we really don't see this effect. So it helps us to personalize the therapy, and then that's really what we try to do in every way. So there are a variety of local therapies. Certainly if there's coexisting psoriasis, topical steroids, coexisting iritis, so about 33% of the patients in our clinic have intermittent inflammation in the eye, called iritis or uveitis. It responds very nicely to topical steroids, but it's very important that our patients are informed about that, and because the ophthalmologists feel very strongly that it should be treated promptly, and our patients, very commonly, and I'm sure many in this room would have the experience of taking your steroid drops with you wherever you go, whether it's on a camping trip or going abroad. You always have your Pred-4 drops. And of course we use local steroid injections when we can if there's a particular swollen joint like a knee. If there's significant arthritis in the hands and feet, what we call peripheral arthritis, this group of drugs called DMARDs, disease-modifying anti-rheumatic drugs, such as sulfasalazine and methotrexate, which are very familiar to our colleagues in rheumatoid arthritis care, probably have some role here. So that's important because there are some patients in which their symptoms are as significant in their hands and feet and legs and arms as it is in the spine. And in those patients, there is really a role for what we call these standard DMARD therapy. But if that's not the case, then if primarily the symptoms and the disease seems to be focused in the sacroiliac joints and in the spine, after the patients have had an adequate trial of at least 2 anti-inflammatories, the next stop really is to move on to what is TNF blockers. The reason for that is that these drugs, the standard so-called DMARDs, like methotrexate, seem not to be effective in spinal arthritis. And yet they're quite effective in rheumatoid arthritis, which is one of the unresolved questions, one of several important unresolved questions. Before we get to just these biologic agents, I will say just a couple points over here. Analgesics remain important even in the era of biologic treatment. We recognize that pain control in and of itself is a very important goal for many of our patients. So establishing a regimen of pain control that works, that's tolerable with the least side effects, is a very important goal as we develop a treatment strategy. I mentioned surgery over here. The most common operation in our patients is a hip replacement. So about 8% of our patients at some point might have hip replacement. It can occur actually in very young patients in their 20s as well. We have a small number of patients that actually go on to spinal surgery. It's called spinal osteotomy, primarily for very significant posture correction. So if they're very stooped and forward, that we are very fortunate having an extremely skilled group of spinal surgeons at Toronto Western, because this is actually very complex surgery that you wouldn't want me in the operating room. The procedures run 8 to 10 hours. And so you really want a very experienced surgeon, but we're very fortunate in that small subset of patients where surgery may have a role. You really want an experienced surgical team. So the TNF inhibitors. So as Dr. Haroon mentioned, TNF is an inflammatory molecule. We don't think Mother Nature put it there to make ankylosing spondylitis. It's probably there to fight infection. That's its normal role. Meaning that in the course of an infection, like a bacterial or a viral infection, your white cells are kicking out this small molecule. It's called tumor necrosis factor. In ankylosing spondylitis, being sort of an autoimmune disease, the molecule is appropriate, the cell that's releasing it thinks it's doing the correct thing, but instead it's attacking normal tissues. Instead of attacking something like a bacteria that's invading us if we have an infection, it's attacking structures in the joints, like the sacroiliac joint. And that's really what the heart of the problem is. So TNF is a normal molecule. It's just inappropriately released at the wrong place and the wrong time. So the big breakthrough with about 1999 was the development of these molecules that actually can inhibit tumor necrosis factor. Because as I said, up to that point, we basically had non-steroidals and analgesic medication and not much else. So this really was a sea change in the management of this disease, because it really changed the landscape for many, many of our patients. So at the moment, there are actually 5 products on the market for ankylosing spondylitis in Canada. One is given intravenously, infliximab. It's given every 8 weeks after loading doses. The others are given by self-administered by subcutaneous injections. Infliximab is intravenously, adalimumab is every 2 weeks, golimumab is once a month, etanercept is once a week, and certolizumab is either every 2 weeks or 4 weeks. So and these are all molecules that are designed to block the effect of TNF. The reason, by the way, they're called biologics is that they're developed through a biological process. So a molecule like aspirin or methotrexate, you could think of as a biochemical agent because it's created by an organic chemist in a test tube. These are called biologic agents because they're not created in a test tube, they're actually created in a cell. So using the techniques of molecular biology, they convince a cell to produce a particular protein in exact replicate copies in unlimited amounts. And so you get these little antibodies, these IgG molecules, that can be injected. They're actually another trick of molecular biology is that they're not really, although they started out in a mouse system, they're almost all humanized now. So most of these molecules are what we call fully humanized. So it's a human antibody that's getting injected in your skin to block the effect. And they've been very effective for many, many of our patients, as you know. So if you've been through our questions, you know we're big on questionnaires. It gets kind of tedious filling those questionnaires. But for something like the Disease Activity Index, the BASD, which is a composite score of how you're feeling in the past week, how stiff you've been, how sore you've been, how fatigued you've been. And almost all the studies track like this, that initially the high scores, once the TNF blocker begins, there's dramatic, and in many, many of our patients, there's been a very sustained effect over time. And this has been very gratifying to see this because for many patients, there wasn't much else to do. We actually don't have any head-to-head comparison of the biologics yet. This includes 4, the etanercept and infliximab. This is Enbrel, Remicade, Humira, and Simponi. We haven't compared them head-to-head, but we think of them as being comparably effective. Why is that? Because in the randomized control studies, when each drug has been compared against the placebo responses are pretty much the same. And you can see by the height of the bar, the responses are about the same. So that's an important point because, as you know, if your physician has given you the option to consider a biologic agent for spondylitis, we now have evidence that you can actually, at least on the effectiveness scale, see several different products that are very closely. The other point you'll notice from this point, this vertical axis is not 100%. So even though these drugs are far more effective than anything we had for spondylitis before, in none of these trials does 100% of patients respond. So that's important, right? So there remains in each of these groups a group of patients that are not going to see the dramatic response we had hoped. Some data from as we've accumulated more experience, that's on the effectiveness side. Safety remains a big issue. Many of our patients are young. They're looking at long-term treatment with biologic agents. So the safety profile is very important for the patients and for ourselves. This actually is data from our own clinic, from Ginny Wallace, who's gone back to the UK after spending a year in our clinic. And the point of this slide is this is the p-value which would indicate some statistical significance between the events. And so if you look at all our patients that had an infection over a fixed course of time in the clinic, the use of biologics does not confer any increased risk of infection from our own clinic. And that's pretty much mimicked by a summary of all the published data last year from Europe. So that's a good sign, but it's not without concern. We always treat these drugs very respectfully because side effects are associated with everything from Remicade to aspirin. And we've got to always be aware of all potential side effects. As the discussion for NSAIDs, which we originally thought were just symptomatic improvement, but maybe more than that. Very early on, there was a lot of interest. Clearly, these drugs were very effective in improving symptoms, but were they doing more biologically? Well, as you know, MRI has really changed significantly our ability to diagnose ankylosing spondylitis earlier, because the X-ray changes that occur in this disease develop over months and sometimes years. But the changes that occur in the MRI almost certainly occur before those X-ray changes occur. So they're quite sensitive, and this would be an MRI of the mid-thoracic spine, a patient that's having persistent upper back pain. And on MRI, this white lesion here represents inflammation. It's what we call edema. So that represents an influx of white blood cells into that area, probably driven by TNF, our old friend. And that inflammation is driving the pain and significant disability of that site. And you can see that after 12 weeks of a TNF inhibitor, that inflammation is essentially resolved. So not just is pain changing, but the image of the inflammation itself is changing. But there remained a very important question about whether or not we were actually changing the course of the disease. It made the patients feel better, but in the long run, did it change outcomes? And this is a study led by Dr. Haroon that included four sites in the United States, San Francisco, Los Angeles, Houston, the NIH, and Bethesda, and Toronto. And the reason that it was an important study in terms of collaboration was that to really detect the effect of the biologics on the course of the disease, we really needed a large number of patients, even far more than any one of these centers could get together. And it also showed the Canadians and the Americans can work very effectively together. So what Dr. Haroon published, and this is a very important slide, is that the effect, it was clearly observed that if patients had started on a biologic agent, it seemed to slow the progression, X-ray changes, the rate of X-ray change in the spine. The metric used there is the degree to which new bone formation has occurred, which is essentially a bone spur, or what we call a syndesmophyte. So you can see here that in patients that developed, if there was a delay of less than 5 years in starting the drug, so if the biologics were started relatively early in the course of the disease, there was a greater effect than if it was started later, that's all. So that's an important message. That's not to say that patients that have long-standing disease don't respond. In fact, we have some dramatic patients who have, even into their 50s, who have advanced radiographic disease, symptomatically have responded very nicely. But this, I think, is a challenge for us in the community, for particularly the community physicians and healthcare workers that are seeing back pain. Because as Michael mentioned, this remains a real challenge in this disease. If you can see, this is actually from a questionnaire that we did with both Canadian and American spondylitis patients, and it looks at the interval between the onset of back pain and the diagnosis of AS. And you see, if you draw this line right across here, it's about 50% line. You can see that about 50% of the patients have at least 6 years of disease before the diagnosis. Now, from our point of view, and I'm sure from yours, that's not really acceptable. And there's something wrong with patients who are out in the community seeing family doctors and sports therapists and massage therapists and chiropractors before they finally get into a pathway where the diagnosis is made. So we're very actively involved in this exercise. We're doing a study with our orthopedic surgeons, Raj Ramprasad, with Laura Passalant, with Chris Hawk, Nigel, on how we can actually get out to the front lines of back pain. Because usually, but once the time the patient's referred to the rheumatologist, that's not the problem. The challenge really is at the frontline healthcare provider that's seeing the patients with him. What's coming down the pike, as Dr. Haroon mentioned, as we understand the immunology of this disease, there may be different points besides TNF where we could actually interrupt the course of the disease. And you can see several here. So, and at different stages. These are the ongoing trials. IL-6 is another small molecule that drives inflammation. It's actually quite effective in rheumatoid arthritis, ineffective in ankylosing spondylitis. Quite a disappointment. We actually were playing one of the lead roles in this study, and we thought it was a sure bet, but there you go. So you can call your broker. IL-23 is a very interesting molecule. This antibody actually blocks two cytokines all at once, IL-12 and IL-23. It's very effective in psoriasis and the arthritis that goes along with psoriasis. And we've seen preliminary data in ankylosing spondylitis that looks very positive. IL-17 seemed to be a key player on that slide that Dr. Haroon showed. And these studies are ongoing. There's just been published a small study from the UK in the Lancet that shows a good response in blocking IL-17. And this is a new molecule. This is a new trial going on. So you can see there's a lot of interest in the industry. P38 was terminated as ineffective. Apremilast and tofacitinib are interesting because they're oral biologics. Everything on all these, everything I've shown on the first slide is still by injection. And I'm sure many of our patients, I'm sure many of you, would find it very attractive to have the option of possibly an oral biologic agent rather than getting a needle once a week or once a month. So these studies are ongoing and we'll be very interested. This is JAK3 is actually inhibitor is actually approved for rheumatoid arthritis and looks very safe. Studying Bowen is an interesting spin-off. There have been small studies ongoing. These are drugs that are usually used for osteoporosis. And one of the challenges here is that osteoporosis, of course, is a disease in which there's too little bone. In ankylosing spondylitis, it's a problem of too much bone at the wrong place. And so we're very interested in this dynamic of what the balance of too much and too little bone is. So just to wrap up, before I pass over to Chris, as I showed on the first slide, it takes a village to manage and research this disease, and you're an important part of that village. This is just some of the members of our team to remind you that there's basic scientists like Dr. Vroon who are plugging away on the basic science of the disease. We have physiotherapists. It's very important to have our pharmacovigilance nurses. Once we start these agents, it's very important that we monitor side effects. And create a database of 1,000 patients requires a lot of effort, and we are very fortunate in having a phenomenally great team to work with who are, each and every one of them is really committed to improving the quality of life of our patients with AS, and that's why we're here. We've had trainees from around the world. I mentioned Denny Wallace went back to England, and in some cases we've been fortunate enough to keep them in Canada, so that's really great. So this has been a very exciting exercise because the challenges we face, our Canadian patients face, are also faced in Singapore, in South Korea, in China, in the United Arab Emirates, in England, in Dublin. There are AS patients around the world that are still struggling with the same challenges.